Good morning, and welcome to today's Oncology Data Advisor interview. Today, I'm being joined by Dr. Sean Collins, who is a radiation oncologist at Tampa General Hospital, University of South Florida. Dr. Collins recently presented a study at the ASTRO annual meeting titled Real-World Data Analysis of Biochemical Recurrence After Primary Radiotherapy for Prostate Cancer, propensity match comparison of patients with hydrogel rectal spacing versus no spacing. And today he's here to tell us some more about this work. So Dr. Collins, thanks so much for coming on the show today.
Oh, thanks for having me. My name is Sean Collins. I'm a radiation oncologist. I live in South Florida. I have the best job in the world. I help take care of men with prostate cancer. There's two different treatment options for prostate cancer. Some men get surgery and some men get radiation. And the goal as a radiation oncologist is to make sure for the men who choose radiation that they have the least side effects possible.
Wonderful. Looking forward to hearing more about this work today. So for background, would you like to tell us what exactly is space or hydrogel and how does it work?
Okay, so men don't know this until they get radiation for their prostate cancer, but your rectum and your prostate are right next to each other. They actually abut each other. And when you're radiating the prostate to cure prostate cancer, you have to give it relatively high doses of radiation. And because of that close approximation, the rectum does get some dose of radiation. By placing a gel between the prostate and the rectum, we put a centimeter gap between the prostate and the rectum. Now, a centimeter doesn't sound like a lot, but with modern radiation, it really allows us to spare the rectum radiation. And you're probably asking, why is that important? Well, if you overdose the rectum, you can get late rectal bleeding, and you can also get bowel frequency urgency. So most men only have one bowel movement a day in the morning. Usually it's after coffee. And but men who've had radiation and their rectums have been exposed to radiation can have multiple, frequent, urgent bowel movements. Now that doesn't sound so bad, to a price to pay for curing your prostate cancer, but most of these men are like 70 years old. And to me, they have limited mobility. They're traveling, they're doing stuff. Do they really, want to be in Paris at the cathedral and then suddenly have a sudden urge to have a bowel movement and not be able to find a bathroom? So as a radiation oncologist, I'm glad I have the ability to actually spare the rectum and make sure that they don't have that bothersome side effect.
Great. Thanks so much for explaining. So what is currently known about its quality of life benefits, and what were the additional questions that you were seeking to answer in this study?
Yeah, so in 2016, I started placing rectal spacers. I thought it was a really cool idea. But really, I'm going to be honest with you, I was very simple-minded. I'd say, okay, we put this gel, separates the prostate and the rectum by 1 centimeter. It'll reduce the dose of radiation to the anterior rectal wall. It'll reduce bowel frequency urgency. And I had very limited, that's how I felt about it, And I thought, that's about all it can really help us with. But there are a lot of smart people have had really interesting things about, hey, why are we limiting this to just sparing the rectum? If you have that gel between the prostate and the rectum, you might actually be able to give higher doses of radiation to the prostate and cure more men with prostate cancer using radiation. Why is this important? Well, men are living longer and longer, I mean, to me, I have a lot of patients who live into their 90s. So radiating them at 70, I have to control their cancer for 20 years. And when younger men get radiation, it's even more important to give high doses of radiation to the prostate to eradicate the cancer in the prostate and cure them for the rest of their lives.
That's great. And then what were the results that the study found?
Okay, great. So this study was looking at by using a rectal spacer, can I improve cancer control in prostate cancer? And this is a flip thinking about it in a different way. There was no randomized trials of spacer versus no spacer that had long enough follow-up to determine whether there was an improvement in cancer control. So we did the next best thing. We got an electronic medical record database, the Truveta database that had 36,000 men in it and with prostate cancer. And about 2,000 of them had rectal spacers, and about 30-something thousand didn't have rectal spacers. And first we looked at what was a predictor that someone like a radiation oncologist would recommend a rectal spacer for a patient. And the number one predictors were localized disease. So if someone had cancer in their prostate, but no metastatic disease, that was a good patient for a spacer. Alternatively, if someone had metastatic disease, there was a concern that there could be cancer in the space between the prostate and the rectum, and it was a bad idea to place a spacer. So those men were less likely to get spacer placement. Men who were getting radiation dose escalation with a technology called brachytherapy got were more likely to get a spacer, likely because the doctors that were taking care of them were concerned that they might be at risk for more rectal toxicity because they were getting a spacer. I mean, getting a boost dose with brachytherapy. Also, it's well known that men with comorbidities like obesity and diabetes, they are also more prone to rectal injury from radiation. So those men were more likely to get a rectal spacer placed. Next, what we did to answer the question of whether it improves cancer control, we did a matched pair analysis where we took 250 patients who had spacers and compared them to 500 patients who didn't have spacers. We looked at their PSA 6 months before treatment, and that was their pre-treatment PSA. We looked at their PSA for the following 2 years after the treatment to see how low their PSA got. And that'd be called a PSA nadir. A PSA is a great test for following prostate cancer. They really know your PSA almost always goes down when you get radiated. And then we looked for PSAs 2 years after the radiation to see what percentage of men failed treatment. And what we found is that about 11% of men without spacing failed treatment, but only 5% of men who got spacing failed treatment. So that was like a 50% reduction in failure by having a spacer. So to me, this is not a randomized trial. This is a large database. And we analyzed it. I think the team did a great job analyzing the results. But this is not the end of this. I mean, what we really need to do is find real world data sets which have a randomization of spacer to no spacer with large percentage of patients that are further out than just 2, 3, 4 years. So future research for this is basically going to be, can we either design a randomized trial, which might not be feasible because it would require a lot of patients, or is there data already available in men that have been randomized to spacer and no spacer that we can get a similar answer to?
Great. Thanks for explaining the results. It's really exciting and looking forward to hearing future research as well.
Yes. I mean, to me, when I talk this research is helpful to me because I see prostate cancer patients every day. So when I see a prostate cancer patient now, I think of spacing, but I also in the back of my head say, hey, this is a relatively young guy with a relatively advanced cancer. I want to give him as much radiation as I can because I want to give him the best chance of being cured without injuring him. So to me, this is like a new way of me thinking about how to use rectal spacers. And by the way, there's lots of smart people out there thinking about how rectal spacers can be used to preserve sexual function, how rectal spacers can be used to preserve bladder function. So rectal spacing is not, just for preventing late bowel side effects and improving late bowel quality of life. There's also alternatives like improving cancer control.
Mm-hmm. That's amazing that it has so many benefits in different areas. Given these findings in the study, did you find any specific patient subgroups who might particularly benefit from spacer placement?
Right. So I would say from this study, most likely the patients with localized disease who are getting dose escalation, either with brachytherapy or maybe a thing called a simultaneous integrated boost to the dominant intraprostatic lesion in the prostate. So patients who have have one area in the prostate that has a lot of cancer, boosting that area to a higher dose improves treatment outcomes. However, it also puts the patient at risk for increased rectal side effects. So to me, this study really makes me think about that patient population and how we can improve their outcomes.
Mm-hmm. Great to know. Awesome. So as I wrap up today, any last insights or key takeaways you'd like to share about this research or next steps or just anything else the audience should know from the presentation?
So for young people out there, I think this is just evidence that in the world, we can always make the world better. We have to have an open mind. We have to be creative. And I think this study shows that when we have a product like the spacer, we really have to think about how to optimize it to help patient care.
Absolutely. Well, this is great. Thank you so much, Dr. Collins, for coming on today to tell us about this research. It's really exciting to hear the results and looking forward to hearing future results as well.
Thanks. Nice talking to you this morning.
You as well.